Hello, my name is Purvik Gowda and I'll be presenting our case on cocaine-induced thrombotic microangiopathy. A little bit of introduction. Thrombotic microangiopathy or TMA is a rare but serious condition characterized by microangiopathic hemolytic anemia, thrombocytopenia, and potential multi-organ injury such as neurological dysfunction and acute kidney injury. TMA syndromes can be divided into those caused by direct exposure, such as thrombotic thrombocytopenic purpura or complement-mediated thrombotic microangiopathy, and those triggered by events like infections, autoimmune diseases, medications, or illegal substances. Cocaine is one such trigger. It promotes endothelial injury and increases the release of von Willebrand factor, which enhances platelet aggregation and eventually leads to microvascular thrombosis, especially in small vessels like the kidneys. Because of overlapping features, cocaine-induced TMA can be difficult to distinguish from other TMA syndromes, especially TTP or thrombotic thrombocytopenic purpura. Let's jump into the case presentation. We report a 66-year-old man who presented to the ED with nausea, vomiting, and generalized weakness. On arrival, he was noted to be severely hypertensive and systolic pressures in the 250s. Labs showed elevated troponin, thrombocytopenia, elevated liver enzymes, and bilirubin, as well as acute kidney injury. He also tested positive for COVID-19. On further questioning, he admitted to recent cocaine and alcohol usage, which was confirmed by toxicology testing. He was admitted and treated for hypertensive emergency and AKI, and his thrombocytopenia was initially attributed to chronic alcohol usage. But by day 2, his hemoglobin had fallen, his bilirubin remained elevated, and kidney function showed no signs of improvement. At this point, further testing revealed elevated LDH, low haptoglobin, and schistocytes were present on peripheral smear. These findings raised concerns for a microangiopathic process. His plastic score was calculated at 5, suggesting possible TTP. While awaiting ADAMTS13 activity results, empiric therapy with high-dose prednisone and plasmapheresis was initiated. He demonstrated a rapid improvement in platelets, hemoglobin, as well as the renal function. He recovered so fast that plasmapheresis was discontinued after 3 sessions due to normalization of the counts. Following discharge, his ADAM-TS13 activity levels returned normal, essentially ruling out TTP and confirming cocaine-induced TMA. This case highlights several important teaching points. First, unlike cocaine-induced TMA, is a rare entity but can mimic TTP very closely. Unlike classic TTP, which is characterized by severe ADAMTS13 deficiency, especially usually under 10%, cocaine-induced TMA typically presents with normal or mildly reduced ADAMTS13 activity. This overlap can easily lead to misdiagnosis or delay in care. Second, although the optimal management of cocaine-induced TMA is not well defined, empiric therapy with plasma exchange may still be warranted, especially when suspicion is high. Most literature supports discontinuing plasma exchange once the ADAMTS13 deficiency is excluded, but in our case, however, the patient improved rapidly with empiric therapy despite a normal level. This suggests that empiric treatment remains justified when no alternative explanation exists. Finally, management does not end with acute stabilization. Substance use disorder is a major risk factor for recurrence, and a multidisciplinary approach, including addiction support, is essential for long-term outcomes. In conclusion, cocaine-induced TMA is an uncommon but serious mimic of TTP. Clinicians should maintain a high index of suspicion in patients presenting with hemolytic anemia, thrombocytopenia, and kidney injury, especially in the setting of cocaine use. Early recognition, empiric therapy, and a comprehensive multidisciplinary approach are essential to optimize patient outcomes. Thank you for your attention.